So today we are going to hear from Erin Sullivan Wagner. Erin is a survivor of anal cancer, and as a result of her radiation treatment, she experienced sexual side effects that went untreated for several months. Because there was no process in place to address sexual health concerns or refer patients timely, the damage caused by radiation became permanent. After her cancer experience, she started a life coaching business for patients called After Cancer Incorporated, coaching on relationship and intimacy challenges. Her focus shifted when she began collaborating with clinicians who were treating patients with sexual health concerns. And through grant funding, she started the All of Me project, developing educational resources for providers and care teams related to addressing sexual health and cancer care. Erin led a team of collaborators in developing accredited interactive workshops, courses, provider resources, and patient education materials. After Cancer Inc. transitioned to a nonprofit organization in 2022, where Erin serves as the executive director. After Cancer provides educational resources, communication aids, and patient materials to providers and care teams on addressing sexual health in a clinical setting. And from there, Erin, I'm going to let you go ahead with your presentation.
Thanks, Rachel. First of all, I'm going to apologize for what a long bio that was. I didn't mean that.
That's
So
okay.
I'll change that in the future. But thanks for the intro. Um, my name, Erin Sullivan Wagner, and you did state it all. I was a cancer patient, longtime survivor now since 2008. Was a life coach and spent years with just patients until I decided really I'd do more good if I could collaborate with clinicians on how to address this in a clinical setting, because the issue really isn't that patients don't care about this. The issue is that it's not normalized for them to really have a space to bring forward questions and concerns. So that's where all the grant funding came from to develop those educational materials. So that's really where I live these days, is collaborating with clinicians on accredited courses for them. But that's kind of a long way to say the topics that I was going to discuss with you today. First of all, my story, not because I think it's relevant to everybody, but I think there is, though it's unique, there is a thread of commonality that all cancer patients have to pieces of the story. So I'm going to go through that, and I won't take too long on it because my personal experience isn't really the point. But then we'll go into kind of what that communication gap is, after reviewing some of the side effects, which, I'm singing to the choir here, preaching to the choir. I know you already know what side effects are, and that it doesn't involve just sexual function, but involves the sexual response cycle. But we'll talk about the communication gap and then what we're doing about it at After Cancer. And then we'll talk about some tips, strategies, exercises that can be done that I've used in my coaching with patients on just some things that might help you personally as you're navigating the intimacy challenges. So, all of that said, I don't probably need to tell you why it's important either that changes in sexual health are some of the most prevalent and distressing effects of cancer treatment. Sexual health side effects, this is the third most common concern in patients. And we know that this partnered marriage, the divorce rate is high anyway. When we're dealing with a chronic illness, it can increase from 50 to 75%. And for female cancers, more than 2/3 of them directly impact their reproductive system. So that's both the gynecologic cancers and breast. So for females, this really is important for female cancers and across all cancer types. So this is everybody. more than 50% will experience sexual health challenges that won't get addressed. So the importance of this is probably um, understood for sure by anybody listening to this. So this starts back in 2008. If you are old enough, you remember Farrah Fawcett also had anal cancer in 2008. So she and I went through it together. Of course, her outcome was much worse. And the reason for that is there is such a stigma around anal exams. So pelvic and rectal exams really aren't something that all gynecologists will do. Mine did, but oftentimes that what happens is anal cancer goes untreated. It goes undiagnosed because they aren't doing a rectal exam and a pap smear in the rectal area. So for me, in January of 2008 is when my cancer was diagnosed, and it was diagnosed because I had a little bit of blood on the tissue with a bowel movement, and that wasn't normal for me. I didn't have a history of hemorrhoids. And so I went in to have it checked, and they thought it was a polyp, did a colonoscopy, realized it was cancer. Wasn't really given much information about anal cancer. I'd never heard of it before. It wasn't kind of a common term used in our house. It was uncomfortable for the kids to say. There just seemed to be a lot of stigma around it. And that was a concern for me. There was even as a patient at one point, I thought, I wonder, I would rather have, a sexy cancer like breast cancer, something that people appreciated and understood. Definitely could quiet a room when you said you had anal cancer. People wouldn't know how to respond. But my treatment was chemo and radiation for 5 weeks. I didn't have to have surgery. I was told 3 times before, from 3 different physicians before I started treatment, that sexual health wouldn't be a concern. So no sexual dysfunction for me because I was young, healthy, sexually active, and I wasn't having internal radiation rods. So I didn't care anyway at the moment, like most patients that isn't your first thing on your mind. Battling the cancer in front of you is. So after 5 weeks, so my treatment was in February and March of that year. In May, I was told I could go back to my life and resume activities like sexual activity with my husband. And when we tried to do that, have penetrative sex, it was so terribly painful. The pain was, severe, urgent. Like there's no way you could get through it, without feeling like you're going to pass out. It was pain that felt like he was hitting a wall or trying to rip through something that had no opening. He felt like he wasn't even inside of me and, wondered about my reaction. So, of course, we just both were really concerned about it and just thought I wasn't healed yet, and waited a couple of weeks, and we tried again, and it was always with the same results. So it would cause blood, it would cause tears, but for sure the grimacing and the look on my face is what was just so evident to him right away, the pain I was in whenever we were attempting intercourse. So we tried different positions, and I thought maybe if I was on top, but that wasn't good. I didn't feel like I had control. And so I had to be on the bottom with my hands over my pubic area, at the upper part of my thighs, kind of like a collision barrier. I just could not move my hands. I know that it was my mind trying to protect myself from what was just such unbearable pain. And when we finally went back at the end of May for the first follow-up appointment, or actually it was in June, I was told that, and it was medical oncology that I went back to. They just said, well, we've never heard of this, but anal cancer is rare, and it's not our problem anyway, because that medical, chemo didn't cause it. And so you need to see radiation oncology. And so I did, and a referral was given to that, and then got there, and they had never heard of it. And I was treated at a comprehensive cancer center. So it's really kind of unbelievable to me that nobody had ever heard of having sexual challenges with this, with radiation. So I was given a a referral to my gynecologist, to the vulvar disease clinic. There, I received dilator tools and estrogen cream, and a referral to a pelvic floor therapist. There was scar tissue built up inside the vaginal walls, and so there was a small procedure done to remove that, and was told use it or lose it because the scar tissue will grow back. We are now into October, and my treatment had ended in March. So it was our attempt to have intercourse was always the very same result. We did have discussion as to whether or not there was any progress made. I knew from the procedure I'd had that I needed to attempt to have penetrative sex as often as I could to keep that scar tissue open. It really was the most difficult thing I eventually had to do, was kind of beg my husband to attempt to have penetrative sex when I knew how much pain it was going to cause me. There was a time when he said, I just don't think I can do this anymore with the look on your face. There's just nothing arousing about this. And I don't want to do it. I don't want to be the source of the pain. I'm not interested. And that was, to me, kind of an all-time low to be at, to kind of beg for this pain that I knew I was going to feel. But because I knew I had to, we chased every treatment you could chase for years. Eventually, I learned what the problem was. The scar tissue had built up around the hymenal ring at the opening of the vagina, so thick that it couldn't be reversed in that time from the end of my treatment to October. And I found it out when I was at an appointment in the menopause and sexual health clinic, who the lead physician said, I'm so sorry, but you just waited too long. And I hadn't waited at all. So it was a tough thing to hear that none of it had to happen, that all of this was preventable. So from that point on, it was more me focused on what had happened over these years with my relationship. And the one thing that is not, even though, I know it intellectually, but emotionally, I couldn't see the gradual disintegration of the relationship, the emotional relationship. I couldn't see it because we were, working to find every treatment there was. But when I was able to look back, I could see that things had changed with us, that even though we were a family unit and we had meals together every night and we knew each other's schedule and we slept in the same bed and went to all the kids' activities, really we had no intimacy anymore. And I could see it in hindsight. I couldn't see it in the moment. And enough time had gone by us that the energy to fix it just wasn't there. And so much anger and resentment had built up. He really didn't think I cared. Even though I was searching for every treatment there was, he really didn't think I cared because I had zero interest, because I had zero libido, because things had changed for me, not only emotionally, but my body had changed. It wasn't so easy to be aroused. The touch, the sensitivity was all changed. Anytime he touched me with his finger, I thought it was too hard and it hurt almost. My skin had changed and it seemed like everything was wrong. And I complained about it or didn't enjoy it, or he was wrong. And he eventually just really had gone from such elation that I was going to survive to disappointment about hurting me to concern over that. And eventually he was just silent. And it's probably when I noticed where we were, when I had no energy or desire and he was silent. So we actually separated for a period of almost 4 years. We did find our way back to each other, but that really isn't the story. So many patients are not dealing with just the sexual function issue like mine. Sexual function was the problem, but beyond that, so was libido, so was body image, which is really the point, is that we're talking about how it impacts the sexual response cycle. I'm going to try to, there we go. So what happened to me is on the top line, and you can see there that everything about me getting treatment happened from the 6 month point on, when really what should happen in cancer care is the conversation should be normalized at informed consent, that the expectation should be set that there could be sexual health challenges, whether it has to do with function or not, that there are going to be referrals needed, possibly to a sex therapist, and that psychological concerns, the counseling piece was something we needed so bad. And we didn't even realize it in the moment that we did. That a physical therapist would be needed, a pelvic floor therapist specific to my issue, and a referral to my gynecologist, that I needed dilator tools. So on the bottom line, if what had happened, if there had been a process in place, everything would have been handled within 6 months, and this timing issue would not been the issue. So I started life coaching after this. And really, I didn't think I was going to be doing that on sexual health. I really thought it was going to be just the emotional piece of this. But I was so curious about everybody else that I was coaching. I was curious about sexual health challenges because it is such an important activity of daily living. It's such an important connection people have with each other in our relationships. And I wondered about everybody else. And almost unanimously, I found from patients' stories that they were impacted, not always by function, but not feeling attractive or not feeling like their partner was attracted to them anymore, having a lot of body image concerns, a lot of fatigue, and a lot of really loss of interest. And this slide is really to say that the cancer-related side effects that impact sexual health are far more than erectile dysfunction and pain with penetration or vaginal dryness, and that it impacts all parts of our lives, physically and hormonally and psychologically, that really sexual health is best understood when you think about it in a biopsychosocial model, and cancer interrupts all of those domains. So the sexual response cycle, this is a one from Masters and Johnson. However, this really applies more to male than it does female. But you can see on the left that arousal goes up as you move through the different phases. Excitement, you plateau to eventually orgasm and then resolution. However, it's really important to note that not everybody gets there at the same time, that this isn't linear for everyone. And there can be a big difference between male and female organ owners. So in 2000, Rosemary Basson developed this female sexual response cycle, which is far more complex and suggests that sexual motivation isn't just present with desire, that external factors actually impact it, like relationship status even. And that this is probably a better reflection, illustration of the female sexual response cycle and how terribly complex it could be. It can be. When I started collaborating with clinicians, I collaborated with those that were treating sexual health challenges, so urologists and gynecologists, not oncologists. And it was because these people really were doing the treatment of it. And I formed a work group within through this grant funding, a work group that this is Dr. Sarah Schaefer was part of this, and she developed this slide, and it really speaks to sexual disorders and pain penetration difficulties, but really just the cancer related, how these cancer related side effects and how they contribute to the web of sexual dysfunction, and how painful sex, you can see through these lines that painful sex is, if you start there, and it can be for a number of reasons that are listed below it, that you can get to a lot of places, but a positive place isn't there. You can get to decreased orgasm or arousal or an unsatisfactory experience, but you're not going to get to orgasm very easily with painful sex. So the mission of After Cancer has been around since I was doing the life coaching, but our mission as a nonprofit organization is really to provide these educational materials for healthcare professionals to address sexual health with all cancer patients, so that all patients impacted by cancer will have this as a standard of cancer care. So we first did focus groups with providers when we started this project to understand why is it a barrier today? Why isn't sexual health? Since really it's kind of pervasive in our society, why isn't it discussed in a clinical setting? And you can probably guess some of the reasons why, but these were the reasons we found out through our focus groups, and we developed our resources based on all of these barriers. The most important being that people would say we have no time. So we developed a 30-second message for all providers to give patients. And in these workshops that we do, we list the side effects that we ask them. We ask the nurses and navigators and social workers and those people that on the care team, what are the side effects of surgery? So for just cancer surgery in general, whether it be breast cancer or prostate cancer, whatever the surgery would be, and the side effects that impact sexual health, it's easy to say erectile dysfunction would and pain with penetration would, but it's more than that. And for what impacts the sexual response cycle, even speech and communication difficulties, I mean, how important is it in your own sexual play to say what you need and want? For people that are unable to do that, it's a huge barrier. So this is I'm showing you this just because it's an exercise that we do to get people thinking beyond the obvious. So what does impact how we feel about as a sexual being, and our efficacy really as a sexual partner? All of these things play. So the impact of chemotherapy, you probably could guess all of these too. Probably the most important to note here, though, is the peripheral neuropathy and how important it is in sexual play to be able to feel and touch and be touched and not have, oftentimes in the fingers, this happens, and just how important it is. So beyond that, radiation, you can see there's a lot of commonality. And when I'm doing this with workshops, we are talking about, of course, the 17 most common cancers with sexual health challenges that go to pelvic floor therapy, the GI and the GU cancers, and then the 4 most common types of treatment that have been studied with sexual health challenges. So it's not all treatment types listed here. It's surgery and radiation and chemotherapy, and then the hormone therapy. So that exercise for providers is a really good thing to do, so they're thinking more in terms of people care about this beyond function. So for the impact that it has on the sexual response cycle, you can see that in just taking it on the in the this one cycle, the excitement is lowered. It's more difficult to even get to a plateau stage. Plateau stage is lengthened. Orgasms are less frequent and less intense, and the resolution time is much longer. So we developed a framework, an implementation framework for providers on how to normalize the conversation, how to set patient expectations and refer patients timely. Those are the three pillars of it. So we do workshops, and that workshop is becoming now an online course. We have an accredited course now for sexual health specialists, where people not only learn about kind of comprehensively sexual health and cancer, but specific to common cancer types, but really just a comprehensive look at how to evaluate for it. How, first of all, how to address it, how to evaluate, how to screen for common issues, how to treat what's common in the clinic, and what to refer out. And then we have a library of patient educational materials that they can order for patients to have in their clinic, or they can do digital downloads. These are just some of the topics, and we also take requests from providers on what they'd like us to do. Like, we didn't have a handout on anal intimacy, but the University of California in San Francisco asked us if we would do one, and so we did. We assume that if you have a patient population, if someone has a patient population that needs something, and a lot of times these handouts are based on, I know our patients need information on it. We don't have time to talk through it in the model, the way we run patients through the clinic. We don't have time to talk about it, but people ask about it. So we feel like we're needing to get this information to patients. That's a lot of times how we get involved, is people ask for something based on what they're getting a lot of requests for. Lymphedema, hot flashes, lubricants, and anal intimacy are the newest ones. So we also teach them in that 30-second message. We teach them how to enter into that 30-second message, what to say in that 30-second message, what to give as a handout, which is really just a communication aid for them, but a high-level overview for patients, just that sexual health matters to us. We know it matters to you, and we're a place to come to. We've got resources to help you. So it's a takeaway. It's a new patient folder item. And then we also go through, where do you refer your patients to? So where are those common places that your patients need to know about? Generally speaking, urology and gynecology and pelvic floor therapy and counseling or sex therapy are for sure the most common places. But some people in their roadmap, they go further than that and go into integrative therapies and mindfulness and support groups. And they find out, where are their resources in the area. So we walk through just tips and strategies for them on how to do that. And of course, the reason being for when, providers really don't think about this very much, but in terms of sex and intimacy and what the difference is, but giving it to them in terms of how patients feel about this is important for them to think about sex as a kind of an umbrella term that can include everything, that including intercourse and outer course and vaginal and anal and oral penetration, and that sex is now considered for physical therapy to be a valued human activity and an activity of daily living. So occupational therapy also, it's part of our daily living. It's like bathing and toileting, and it needs to be considered a quality of life concern. And when we think about it that way, it makes it a little more urgent for providers to think we need to bring this up to our patients to give them some awareness. So, of course, sex associated with intimacy, they aren't interchangeable. There's emotional intimacy, physical intimacy, and sexual intimacy. And of course, all of those areas of intimacy were impacted with what happened to me, and a way to get back intimacy there is a way to concentrate on that emotional, physical, sexual piece in different ways. So the bonds of emotional intimacy. So this is what I did with patients when I was coaching. So emotional intimacy for my partner and I really was based on pillars of what was important to our relationship, what made us strong. And it came down to, and this is common for a lot of relationships, to communication, physical, security, and shared values. There are some different things that could be here, but what was important to us from a physical standpoint was the touching, the cuddling. For my husband, it was the kissing, and of course, then physical, sexual intimacy. Communications for us, everything that was important about our relationship. So everything that we were constant about, shared values and security. When the physical side changed for us, when penetrative sex was no longer an option, we didn't know what we were dealing with. So we didn't, time out. What are we going to do about this? We need to give and receive pleasure another way. We didn't do that. We stopped what led to having penetrative sex. We stopped cuddling, touching, for sure the kissing, because it was such a launch sequence that we went through. Kissing was always, the start of what would lead to penetrative sex for us. So we stopped those things because they were disappointing. They were painful. It was just calm. It was just easy to not do the things that were going to put you in a situation where you were going to be so compromised. But what happened when we didn't fix that? It impacted how much we flirted with each other and spoke to each other, and that alone time we had with each other. I used to remember, whatever the stupid NCIS show would be, 9 to 10 o'clock. My husband would watch that, and we would cuddle in bed. We would talk a little bit about the day, and just, it was a kind of watch the show, kind of talk. It was just our time. And I didn't even realize it at the time, but between 9 and 10 o'clock at night, it was our time. And when I look back on it, I remember going from that being kind of religious for us to that was the time I called my mom, was during that time. I don't think I ever really realized it in the moment, though, that that's what was going on. So because that relationship changed from the physical aspect, because we didn't fix that, it eroded every single other pillar of strength we had at emotional intimacy. And I can look back and see how it changed the respect we had for each other. It eventually impacted fidelity. For sure, it impacted how we even planned family vacations. It impacted every area of our life. So as an exercise, what I would have patients do is think about where your emotional intimacy is, where your foundation for that is. What are those pillars? What does make you strong in the relationship you have today? Think about it and protect what you can there. Don't let one area end up being the reason everything crumbles. And none of this stuff happens overnight. It all happens over time. So it's something to do together in a partnered relationship, is to think about these things that make you strong. Of course, emotional intimacy from an individual standpoint, not in a partnered relationship, is also important, because emotional intimacy really is what we all want in our lives, that peace. So from an individual standpoint, you can also do this same thing. Think about what keeps you joyful and happy and at peace with your life? What are those things you do, those behaviors you have, those thoughts you allow that keep you there? You can also list that out. So just another exercise to do. Of course, there's tips for communication, and none of these things are, wow, never thought about that. I almost could leave this out, except that it is fair to say there are some things when you need to talk about sexual relations. It's difficult to do that with the person you sleep with for some reason. It's just so difficult. But if you follow just a few tips, it helps a little. If you're going to have these conversations, have them outside the bedroom. It's just smarter. You can be more objective. And I used to say, let's talk about something. And he dreaded it. I knew he dreaded it because he felt like it was going to be criticism of him. And, for however long I chose to do it. So keeping conversations kind of like, hey, Saturday morning, let's go for a walk and just talk about where we are, how we're doing. Like no more than 20 to 30 minutes. We're not going to do that. We're just going to have small pieces of conversation to try to find each other again. Straight talk, that whole thing about sex isn't good for me anymore can be misinterpreted. And it's a common thing that people say is, I just don't have any desire for it. And how that's interpreted is often not what we think it will be. So active listening skills really is what most of this comes down to, hearing people's thoughts and fears, being honest about it, and consider rewriting sexual scripts. And sexual scripts are important because sexual scripts are really the scripts we have in our partnered relationships. They're the scripts we have that we haven't even thought about, but they're the way we launch from this non-sexual sequence. It's a sequence of events, but this non-sexual being to a sexual situation. So how does that happen for you? Is it always the same thing? Is it, do you signal that? Is it always starting with a kiss? Is it always Saturday night after a movie and dinner? Is it, when I don't have my footy pajamas on, so that signals something? What are your scripts? Almost always after cancer, these have to be rewritten. Spontaneity isn't there anymore. And there's sometimes pain pills that have to be taken before you could even attempt that. It's right to think that the scripts you used to have when you maybe fell in love with this person aren't the scripts that work anymore. So one of the things that, how do I go back? Nope. How do I go back? One of the things that on sexual scripts, let me just tell you, what you can do as an exercise is write down two of the scripts that you've always had that always worked. When you can think of it when we were young, but when we fell in love, what were the scripts? Think about how they don't work anymore and what you could do, just what you could do to impact how a new script could be written. What would need to change in that? And this fourth exercise is sensate focus. And this is a touching exercise. If you haven't heard of it before, you can Google it. But there is actually a handout on this too, but it's a great exercise for learning how to touch and be touched and how much pressure is needed that feels good. And it's a way to emotionally see the other person. And it is a step-by-step. So there are 3 different sessions, and really it's not meant for arousal at first. It's not, in fact, that is off limits. That's not what it's for, but it's to learn how to touch and be touched. It's a great exercise. And the fifth exercise is something that I use with patients because it was important to me. This is a letter of reflection about what cancer changed, what it changed about you, what your new fears or thoughts or feelings are about it, what you wish somebody knew without having to be told. What is going on in your mind that you're not saying out loud? This exercise can be done as just a way to reflect for yourself, to get clear about your points in an uninterrupted way, to be able to list things out. You can choose to give this letter to someone or not. When we were apart, I chose to let him know. I did do this actually. And when he received it, he he and I did talk, and he said, "Oh, you're so wrong. I didn't care about intercourse like you say I did. You stopped kissing me. You stopped kissing me. You'd never kiss me." And he was right about that because I knew where it led. We also didn't talk about it. But it was a way to open up my feelings about it, what was true for me about what cancer had changed in me. And it also gave us a foundation to talk again. That isn't necessarily what the goal is of it. It is really more of for the patient to be able to reflect on how things have changed and what they want next. These are 5 exercises that some patients found helpful because they hadn't thought about it before. But I know none of this is, for sure going to take care of whatever the issues are. These issues are complex. I really think it's important to concentrate on it, though, because finding intimacy again shouldn't be impossible just because you've gone through cancer. I am going to leave my email address, my phone number. If anybody has any questions, reach out about anything. I'm happy to help in any way I can. I'm available for questions now, though, if anybody has any.
Great. Well, thank you so much, Erin. That was really very informative. And honestly, I wish this had been around 20 years ago.
Quite.
Yeah, right, right.
Yes.
So I have a question. How do we educate our providers about this topic? I mean, none of my providers have ever brought up sexual health.
Yeah, well, I'm doing what I can there. So
Right?
we are, we're a small nonprofit, so it's difficult to get this to a place of being kind of a standard of care for patients. It really needs to be taught in nursing schools and PA and NP schools, and before people are figuring out what the process is of clinic flow. We do work with survivorship clinics. We're trying to get it not in survivorship, though. National guidance tells them that addressing sexual health at the diagnosis is necessary. It's just so easy to turn a blind eye to it, though, because as a patient, it's not where my head is. As a provider, the oncologist, it's not where their head is. But when I push back on providers who are uncomfortable or say their providers are uncomfortable, so physicians, when I push back on oncologists, if your patient, they're afraid that the patient might be offended or emotional. If your patient was offended or emotional that you were wanting to talk about bowel function or incontinence, would you not do it? And of course, they always say, of course we would do it. That affects their quality of life. Bingo, it does. Overwhelmingly, when providers start to address sexual health and cancer care, overwhelmingly, they are met with, thank you so much for caring about me.
Yeah.
It just isn't a place they are forced to go. So giving patients, so I've been asked if we would develop a course for patients. And as much as, I want to help patients, I just want providers to do their job. I can't help all patients. Patients are never going to all know about me. The responsibility is with the provider and the care teams to address all of what the patient considers quality of life for them. Because though in the moment cancer is the most important thing, we all want to go back to our lives when we're surviving cancer, when we're in survival mode. Eventually, you don't spend every day just being grateful that you're breathing. You do want the rest of your life, or as much of it as you can have back. It's not wrong to think like that. You shouldn't have to feel greedy.
Right.
Like you bargained, you already bargained with God about it, so now you really can't. No, that's baloney. This is a quality of life issue that should be talked about up front so that you have every ability, every chance to get the help you need in a timely manner. Some side effects need to be addressed sooner versus later.
I have another question. Oh, go ahead, Jill. Do you have a question?
No. I'm in the UK because obviously you're both in the States, and like you said, Rachel, I'm coming up 66, and 20 years ago this would have been helpful to me too. But whenever I attended a menopause clinic here in the UK for 20 odd years, and my GP, I believe you call primary care provider, I remember as a woman who I knew for over 20 years. And when I brought up something about sexual health, she was embarrassed. She just couldn't handle it. And the same even on the menopause clinic. There's a woman, gynecologist, and I've had problems with vaginal atrophy because chemotherapy put me into a very early menopause at 28. I took hormone replacement therapy, but over time, even that wasn't enough. But I tried to speak to them on the menopause clinic again. They were embarrassed. They didn't really know what to say. Or they said something about dilators, but they didn't say where I could get them from, where to go. And they sort of they mentioned it and sort of pushed me out the door, really, which wasn't ideal.
Well, no, and nothing like shutting you down forever.
Quite.
If you're pushed out the door, it's just such a not welcome topic. You'll never bring that up again.
It's a shame. I think it's a real shame. I'm an ex-registered nurse, and I can talk about anything and everything. But I found the medical staff quite disappointing. And it was interesting. It was two women. I did meet a new gynecologist, and he was very good, but unfortunately he retired. And he was the one who, when he first examined me, he said, "My goodness, the level of vaginal atrophy you have is spectacular. I'm not surprised you've got problems." Mm-hmm. And that's despite me having hormone replacement therapy and using all. I was buying lubricants. I do a lot of research, and even that wasn't enough. Mm-hmm. And he tried his best, but as I say, he retired and moved on. But it's interesting. It was a man that was easier to talk to than talking to a woman.
Well, so that actually, great point, Jill. And it really is important for providers to understand that your patients are going to be as comfortable as you are and not any more comfortable than you are. So you can see in body language and the words said and the tone, you can tell when somebody's comfortable or awkward about a topic. And too bad that you had to bring it up to anybody, but them being awkward and uncomfortable about it, there's no way you'd ever give a chance doing that again. It's just their responsibility to normalize this conversation for patients so that if they've got questions or concerns, they know where to go. There's so many ways to normalize it. You can do it with messaging and signage and your words too. I wish there was more I could do to make this mandatory, like it be mandatory that in academia.
Yeah.
Oncology it's because it's oncology. We don't ask oncologists to do this. We ask the care teams, though. Anybody who is speaking to patients about side effects should learn a 30-second message. It's got 6 points to it. They should know how to enter into the message and transition out of it. Everyone should know that. And in doing that, you then take the monkey really off your back and you let the patient know that if they need something, you're somebody that cares and will help find resources. That's all they need to do. 30 seconds. We know they don't have time. They've got 30 seconds.
Yeah. I think we tend to be 10 years behind the States here in the UK anyway. A little bit, it's improving. We've got some what we call late effects clinics here, but they're still not really addressing sexual health enough. I was treated 41 years ago. So, it's a long time ago. And then there was absolutely nothing.
Right.
Absolutely
right. There was nothing. Right.
Nothing at all. We didn't have the technology. We didn't have anything. There was no leaflets. There was no mentoring. There was nothing. No support groups, nothing.
Wow.
And, only having been married for 18 months and then being diagnosed with lymphoma. We got through, but it was very hard. My husband and I, we've been married 43 years on May the 1st.
Oh, congratulations.
Yes, thank you. He's stuck with me through thick and thin. But it has been hard, and it's been very hard on him, I have to say. It's been hard on me, but I think in some ways it's harder for your partner.
Yeah, I would agree with that. And it's hard for the partner who has interest.
Yeah.
Absolutely. So whoever that is.
Yeah. He, bless him, I say he's been very good. He's been very supportive, but from our sex life point of view, he's just switched off. He just accepts that now it doesn't happen. And it's hard for him and it's hard for me. And I've tried everything that I can possibly do, but I have the pain scenario and the atrophy is so bad. I could so identify what you're saying about grimacing because it was so painful. And of course he doesn't want to hurt me, and you're in this cycle and you can't get out of it. It's really difficult.
When 2 years into this, one of the appointments, I was given Xanax as a treatment, as a way to help with the symptoms. And my husband was there. And when we left there, he said, "Do you think that they think this is all in your head?"
So when you say Xanax, is that diazepam?
Yeah.
Yeah, but it's okay. We use the we don't use proprietary names, but I think I've clicked. Well, that's crazy.
Right. So they gave me anti-anxiety medicine.
Wow.
And he asked me, and of course I, with the question, I thought I was hurt by the question. I felt some betrayal that he would ask me that. And so it was this horrible conversation that ended pretty abruptly. But I said to him, do you think this is in my head? And he said, "Well, I wonder, Erin, they told you wouldn't have any issues. They have never heard of this before. No other patients have had issues, and they've treated it in every way they know how, and nothing matters. I wonder if maybe you have trauma from the first time and you're just reliving that in your head."
Wow.
And that felt to me like such a betrayal. I could hardly speak to him because he didn't know the hell I was going through every time. He didn't have that pain.
Mm.
But when I thought about it, I blame the providers and my care team for my husband even thinking that.
Mm.
Of course he thought that.
Mm. Yeah, they should make that
How
clear
could
that
they
it's not
not
in your
know?
head.
They
Mm.
should
If they
know
had asked
better.
any patients,
Mm.
they would have known.
Yeah. And of course, they provide anxiety medication whenever they've run out of ideas.
Yeah.
Like, you know,
So I took it, of course. So I tried it and then fell asleep, So
Yeah,
right?
exactly. It's
Like,
rather
yeah,
counterproductive.
totally counterproductive.
I know. I mean,
You know this.
I take duloxetine as part of my pain medication because I have neuropathy and I have radiation fibrosis, which a lot of us do for my group,
Mhm,
and
mhm,
that doesn't help either. It just
Not at
doesn't.
mhm,
You
mhm.
know, to totally identify. The medication causes problems as well, but it's weighing up. You know, if I didn't take gabapentin, if I didn't take the duloxetine, which is recommended by what we call a community pain clinic here, I would be struggling even more because I couldn't function because I was in such pain from the radiation fibrosis
Oh,
anyway.
wow.
Yeah, so I'm doing better with pain relief with that and an exercise program. But it took me, I mean, I was lost in the wilderness with it for 20 years and getting no answers at all. I had to contact Michael Stubblefield in America because it wasn't recognized here. So I only got actually confirmed diagnosis in 2014. So we're talking 11 years ago. But I'd actually had it started about 10 years out. So I've had problems with it for sort of 30 years, very gradually. But it's all a steep learning curve, as I call it.
Mhm,
And that's how you have to look at it. Well,
mhm.
that's how I look at it. I'm not saying it's right for everybody.
Yeah, yeah.
Unfortunately, my my husband and I, our relationship has survived. It's not easy. It's not easy, and it, I can see our relationship is very different now to what it was when we were much younger.
Mhm,
But we've known each
mhm,
other for a very, very long time. From teens, we met at school, so we've
mhm.
been known each other for a very long time. So it's approaching what 50 years almost.
Yeah. Well,
Yeah.
congratulations.
Thank you.
Yes. We have that in common too, Jill.
Oh, good. Oh, right. Okay. You've been
And
with your partner for a long time too.
yes, yeah.
Yeah. Yeah.
So, Erin, I have a question. Does this topic get addressed more by men or by women? Is there a difference between the like how people get their sexual dysfunction addressed? Are men
Mhm.
more likely to yell at, hey, I got a problem to their doctors and women are not? What's the deal?
Well, it's interesting. So studies with female organ owners are about, I don't know, probably 10 to 20 years behind what studies are doing for male organ owners. So we really do respect men's sexual health more than
Mm.
we do, especially in preservation terms.
Mhm.
There isn't a treatment for females that has any weight and watch to it.
Mm.
But of course, there is in prostate cancer. So, what we find is that oftentimes there's a better chance that men will learn about sexual health challenges in an informed consent appointment. So, before
Mm.
treatment, they have a better chance then. And it's because there is this kind of assumption that this is important to you, it's important. Not so true with females when you look at the studies of what providers do and what the female patient hears. But at the same time, you'll you'll hear anecdotally that prostate cancer providers will say that it's the female partner who bring it up. So
Mm.
it's not the patient that's male. It's either the provider assuming the patient cares or the partner to the patient.
Interesting.
And
Huh.
that, but that's anecdotal. So
Okay.
I'm not quoting a study there, but I can understand that. I can
Mm.
believe that commonly, so really general here, that females might have a easier time speaking about it,
Mm,
um, and maybe for their partner, kind of caring for that person.
okay.
Uh,
Mm.
Not necessarily because, oh my gosh, what are they going to do if he can't have an erection, but more in a caring for my partner
Hmm.
kind of way.
That makes sense.
Yep.
Yeah. And then there are survivorship clinics. So, it really runs the gamut. Sometimes people will say just exactly what happened to Jill and I. Nobody brought it up. Nobody talked about it. Nobody. In fact, I was told I wouldn't have any issues. Just, not only not talked about, but told not to worry about it.
Hmm.
Some, sometimes that's where we are. It can be as far as that to survivorship clinics that are designed so that they will help patients with these topics, and it's designed that way. So it'll come up throughout their treatment, either during or at the end of active treatment. So sometimes, I know I'm saying not everybody has just active treatment and then that's it.
Right.
But when there is an ending to active treatment, that's often a trigger for these long lasting side effects to get talked about, survivorship issues. So this ends up in survivorship right now, but that's not where it belongs. It belongs at the
Mm.
diagnosis. So we keep backing it up as much as we can, understanding that patients don't care about it at the diagnosis necessarily.
Mm.
Right.
Our point is they need to know about it, though. They need to watch for changes. They need to know changes may occur. They also need to know that some changes have to be addressed sooner versus later to have a better chance of them being resolved. They just need to know the information. We don't need
Mm.
to do a sexual history. We don't need to ask who you're sleeping with. We don't need any of that.
Right.
Patients just need to know that sexual health side effects are common and expected with cancer therapies.
Mm.
Yeah. Very interesting.
Yeah, there are some, and sometimes it's just the
It
provider you have.
is. Yeah, there's a push right now happening towards onco primary care physicians.
Mhm.
And I mean it's a brand new area. So
So I applaud that.
yeah. And I think, oh, they should be the ones that, once you're passed off from your oncologist to a primary care physician, that half the time they don't even know like how to care for a cancer survivor.
Agree.
But
Agree. I think there is another concern there that
yeah,
they are not sure how to touch the cancer patient because they're afraid of doing that.
right.
However, I say that ends up being like a survivorship clinic where it's too late sometimes. So that's not quite good enough that it's going to be your primary care you go back to. It's something though. I applaud primary care getting very involved in how to treat that cancer patient because, more and more people are surviving their cancers.
Mm.
Right. There's 500,000 in the United States, 500,000 cancer survivors uh right now, at least. There's
Well,
probably
if you're
more.
talking
Yeah.
about just survivors,
Yeah, there's way
there's
more than that.
18.1
Yeah.
million of them,
Yeah.
that have been diagnosed, have been impacted by cancer at some point in their life. And that's about half and half, female and
Yeah.
male.
Yeah.
And more all the time,
Yeah,
that
it's going to grow. It's going to grow here in the UK
that's
too.
right.
Yeah,
Absolutely.
and it's more common now with younger people,
Yeah.
which means it's going to have a huge impact on sexual health and uh,
And
lung.
that's the other thing is that sometimes when you wonder if male get treated differently. Sometimes the young get treated differently. Um,
Yeah.
Young heterosexuals have a better chance of somebody caring about this than for sure anyone that isn't in that group. And that means, up to 40 maybe.
Yeah.
I'm sure you're right. Sadly,
Mm-hmm.
I'm sure it's the same here too. We do have a teenage and young adults cancer
Mm-hmm.
set up here. I don't know if you do in the States.
We do. So we do. People specialize in adolescent and young adult.
Yeah.
However, not always is there a specific clinic for them. Some of the larger comprehensive cancer centers have specific clinics like MD Anderson and not just them, but large cancer centers will have maybe a special clinic that is just for the adolescent and young adult.
Well, thank you so much, Erin. This has been really, really helpful, very much a needed conversation. I'm sorry more people didn't show up, but I'm betting this will be one of our most viewed YouTube videos.
I guess it will. I think a lot of people find it difficult to participate.
Right.
Well, that's my feeling. And people would really love to, but just can't bring themselves to do it.
Yeah.
Just that, I think that is true. I think that's hard for people to participate. There might be a way that you can have speakers on this topic and have people, but they don't come on camera. They aren't named. So they're
absolutely
just people can listen and put in their a way to send a question to either the presenter, because the presenter won't know anybody, but not have them on camera.
We'll do that. We'll do that again at some point.
Thank you so much, Erin. I appreciate it.
It was nice to meet you, Jill. Thanks for your questions.
Yeah, nice to meet you too. You take care now.
All right.
Well, thanks, Rachel, for filling Erin's shoes as well.
I'll never do that.
Yes, thanks, Rachel.
Somebody's doing it. Yeah, thank you very much.
All right.
Take care, both.
All right. Bye-bye.
Bye-bye now.